Welcome to the Practicing Clinicians Exchange podcast. This podcast series was developed from a live PCE conference focused on gastrointestinal and genitourinary cancers, including gastric cancer, colorectal cancer, hepatocellular carcinoma, bladder cancer, and prostate cancer. In each episode, you will hear the latest evidence and expert recommendations for the care of patients with a specified malignancy. In this podcast series, each of these topics will be discussed in 2 podcast episodes covering didactic presentation of the available evidence, relevant case discussions to illustrate clinical implementation strategies, and the audience Q&A session. Be sure to listen to the 2 podcast episodes for each topic in sequential order, as they may include examination of continuing case studies with patients progressing through different stages of their care. To claim your credit, please visit pce.is/GIGU.
I'm Terran Sims. I'm a nurse practitioner at the University of Virginia, Department of Urology in Charlottesville, Virginia. Our topic is advanced urothelial cancer, applying new therapeutic options. Our first speaker will be Dr. Balar, an associate professor of medicine at the Division of Hematology Oncology at NYU Langone Health, New York. Here are our learning objectives for this session. We'll identify the appropriate use of clinical practice and novel emerging therapies for advanced urothelial cancer. We'll describe toxicities of novel therapies for advanced UC. We'll implement strategies for the management of toxicities associated with novel therapies for UC.
I start basically any conversation about bladder cancer by giving a little sense of overview in terms of demographics, a little bit of epidemiology. So it's an extraordinarily common malignancy of the urinary system. It's actually the 6th most common cancer and the 10th leading cause of cancer death in the United States. It's a common malignancy of older individuals and age distribution there based on new cases by age, really clustered in patients around the age of 70. So 65 to 75 is the majority of the patients who are diagnosed. And depending on what series you look at, roughly a median age of 73, I think is a reasonable median that you can kind of peg around. And 3/4 of patients are above the age of 65. And certainly the incidence mortality is certainly higher in men than women. The primary reason for this is that this is a carcinogen-induced malignancy, the most common risk factor being smoking, and then also patients who are in the chemical and dye industry. Those exposed to chronic solvents like aromatic amines and dyes and so forth are the patients who are at risk for the development of this disease. In chronic carcinogen exposure, many patients will ask, well, how does it develop? It's because it concentrates in the urine after circulating throughout the bloodstream. When the urine sits and dwells inside the bladder, chronic exposure to the urinary lining inside the bladder is ultimately what leads to the development of bladder cancer. The inside lining of the bladder is called the urothelium. That's the primary lining. It was previously called the transitional cell epithelium. So before, what used to be called transitional cell cancer and urothelial cancer, these terms are interchangeable. Although, urothelial cancer is the more preferred term, the more modern term. And it arises from cells that exist in that first layer that is in the lining of the bladder. Now, within that layer, there are also basal cells and luminal cells that can have actually differential genomic expressions. But for the purposes of our talk in this conversation tonight, just say, it's really that urothelial lining that becomes cancerous. Now, the cancer can develop, and, once it develops in that lining, usually as a consequence of chronic carcinogen exposure, it can grow either along the lining. We call that carcinoma in situ. It can grow as kind of these papillary fronds or these tumors that grow into the empty space of the bladder. We call those papillary or TA tumors. And then they can also grow into invasive tumors that grow into the first layer below the urothelial lining called the lamina propria. And collectively, CIS, TA, and T1 are collectively called non-muscle invasive bladder cancers. We treat them quite differently than the other stages, which are T2 or greater, which are muscle invasive tumors, primarily because of the risk of subsequent metastatic spread. Once the tumor has access to the muscle layer, which is the detrusor muscle of the bladder, the dense network of capillaries and venules in that area really give access to the rest of the body. And patients who develop muscle invasive disease have upwards of 50% risk of development of metastatic disease. And therefore, it's a more aggressive tumor. And the treatment, therefore, in terms of aggressiveness also escalates. Localized treatment with TURBT and intravesical therapies is the mainstay of treatment for non-muscle invasive bladder cancer. It really ratchets up once patients have muscle invasive disease to include either radical cystectomy or chemoradiation, primarily because of this subsequent risk of dissemination into metastatic disease. And that's even with, definitive local therapy. I kind of touched on this previously, but here are some of the primary risk factors for the development of bladder cancer. Majority are smokers, and it's cumulative risk over time. Pelvic radiation, for other malignancies can also raise the risk for bladder cancer, but Most often, we see sarcomas develop as a consequence of pelvic radiation, and these can often develop 10 to 15 years after pelvic radiation. So a different type of histology within that context of bladder cancer. Men favored 3-1 over women. Certain familial history, such as HNPCC or Lynch syndrome, so patients with that genetic history can be at risk. Other behavioral, occupational risks that can be associated with it, including other medications. The TZDs, which are a class of diabetes medications, have been linked to the development of bladder cancer, and also cyclophosphamide. Its metabolite called acrolein can actually accumulate within the urinary system and can also lead to the development of bladder cancer as well. What are the principal signs and symptoms of bladder cancer? They're focused on the bladder. So painless gross hematuria, far and away the most common symptom, and this is the entry point into the healthcare system for patients with bladder cancer. It's either the blood that patients can see, or it's the blood that the primary care physician detects on their routine urinalysis, let's say during an annual physical or so forth. But then the other symptoms are also concerning, such as irritative symptoms, frequent urination, difficulty urinating. All of these symptoms also can mimic UTIs. So men and women who come to the primary care physician or others with recurrent urinary tract infections that are then treated, and then they get better, then they get worse, and back and forth again, ultimately then are diagnosed with bladder cancer. This may actually be a reason why women actually have a slightly delayed onset, delay in diagnosis, because women are more likely to develop urinary tract infections in older age as compared to men. Men who develop UTIs are going to be probably earlier to get a cystoscopy, for instance, than women might. And so this may actually contribute to a delay in diagnosis in women as compared to men. Patients ask, well, why is it that, UTIs are linked to bladder cancer? It's actually not. It's the other way around. Once patients develop bladder tumors, the urinary microbiome gets completely disrupted, and, pathogenic bacteria accumulate within the bladder and lead to UTIs. So basically what happens is that you keep treating the urinary tract infection because the superinfection occurs, but that bladder tumor is obviously still there, and ultimately it needs to be diagnosed. Metastatic bladder cancer depends on where it goes, right? So depends, weight loss, fatigue, unexplained symptoms that can affect other parts of the body, such as bone pain, essentially the symptoms of advanced cancer. So let me hand it off to Terran to discuss the next case, Sean, our 68-year-old gentleman.
He presents with a UC metastatic to lymph nodes. He smoked cigarettes for 20 plus years that he quit about 10 years ago at age 58. His medical history is important for mild hypertension, for which he takes amlodipine, no family history of cancer. His physical exam was pretty benign, 5 foot inches, 153 pounds, heart rate and blood pressure normal, blood pressure a little bit high. Relevant lab results included creatinine of 0.8 and LFTs within normal limits, and his molecular profiling shows no actionable mutations. So, what is the most important thing to determine before planning first-line treatment for Sean?
The most important thing to know about a patient with newly diagnosed advanced urothelial cancer is to know whether the patient is eligible for cisplatin-containing chemotherapy. That's the most critical kind of decision point you need to make. And it's because cisplatin-based chemotherapy is the first treatment of choice. It's associated with survival benefit and even some cures in some patients, and largely driven by the sites of disease. We, long-term data, long-term studies in patients treated on the original MVAC studies going back to the late 1980s, and even the more modern studies involving GC versus MVAC have demonstrated that patients with, node-only disease, often limited to the, retroperitoneum and the pelvis, can actually be cured with cisplatin-based chemotherapy. And so really it's important to understand whether patients are first eligible for cisplatin-containing chemotherapy. But what we also know is that there's a somewhat poor tolerance, and many of our patients don't have a long-term durable response to chemotherapy. And upwards of 50% of our patients are ineligible for cisplatin-containing chemotherapy. The primary factors that drive this, age is listed there, but age is kind of a surrogate for a lot of other things, right? So there's an age-related decline in kidney function. So sometimes those two things are paired together. And also with age, sometimes there's a decline in performance status. So really it's performance status and kidney dysfunction. Those are the two primary objective factors that drive cisplatin ineligibility. Other relative factors that we include also in our regulatory definitions include neuropathy and heart failure. Heart failure is often listed because patients with, poor ejection fractions aren't really able to handle the large volume requirements, IV fluid requirements that are required for co-administration along with cisplatin. And so patients, are at risk for, heart failure exacerbations and so forth to be able to safely receive cisplatin-based chemotherapy. Oh yeah, and not to mention patients with heart failure also, can also have concomitant kidney dysfunction. So a lot of times, these medical comorbidities really, they migrate together. So certainly alternative treatment options must be offered for patients who are not eligible for cisplatin-containing chemotherapy. So very important. Again, takeaway, determine first if the patient is eligible for cisplatin chemotherapy in the first-line setting. That's the most important thing that you do. All right. So what are alternative first-line options? So let's say you made the designation, I've got an older individual, maybe they're in their late 70s, maybe they're early 80s, they have bad cardiovascular disease, maybe they have, bad kidney function and so on and so forth. What are the other options to consider? Well, carboplatin-based therapy, which is often considered the kinder, gentler platinum, can often be considered. Data has shown, even randomized trials, that suggest lower response rates, although modern trials suggest that maybe that differential in response rate difference is probably not all as large as we used to think it was. Shorter duration of response, that's always going to be the case with chemotherapy in general, or lower overall survival. And there still is substantial toxicity. So what we trade off with cisplatin, which cisplatin is associated with nephrotoxicity, neurotoxicity, and ototoxicity, we trade off with carboplatin and gemcitabine often, which is bone marrow toxicity. That's kind of the trade-off. So immunotherapy, was developed. Single-arm studies, KEYNOTE-52 and IMvigor210 cohort 1. It led to accelerated approval for both pembro and atezolizumab, respectively. First, broader labels in 2017. Let's fast forward to April of 2021. And then more recently, we have, I think, really now codified where these both agents sit for pembro. It's for patients that are not eligible for any platinum-containing chemotherapy. So it's very important to understand. So those patients who, again, are just poor protoplasm that you're really worried about the safety of any platinum, whether it's carbo or cis, then it's a reasonable choice for that patient. And then it's also available as a second-line option after progression on platinum-based chemotherapy. So there's a clear survival benefit. And for atezolizumab, it's still available as a single agent in cis-ineligible patients who have high PD-L1 expression, and also for those patients who are not eligible for any platinum-containing chemotherapy. Why is it that we have to be very careful about this? Response rates are lower with single-agent immunotherapy in the range of 20 to 30%. Chemotherapy response rates are higher, 40 to 50%. And especially for patients with high-volume disease that's progressing very quickly, you don't want to take the chance with immunotherapy. You really want to treat with chemotherapy first, and then perhaps follow up with immunotherapy later, either perhaps as a maintenance approach. And now that we have level 1 evidence demonstrating that is associated with survival benefit. So let me hand it back off to Terran, who will continue with our case about Sean.
All right. So Sean is cisplatin eligible and gets 6 cycles of gemcitabine cisplatin. He has an 80% reduction in his lymph nodes. Given a choice between being monitored or receiving maintenance therapy with avelumab, he decides on avelumab maintenance.
We have level 1 evidence showing an overall survival benefit with avelumab maintenance, but it's important to understand the context in which this trial was conducted. So it took a group of patients, 700 to be exact, patients who had already received a standard of care platinum plus gemcitabine chemotherapy. It was basically a 50-50 mix, or pretty close to it. Some had received cisplatin gemcitabine, others had received carboplatin gemcitabine, and had achieved stable disease or better already as part of their standard of care, and then had a 4 to 10 week treatment-free interval. Then in that process, they were consented and screened and randomized to either receive avelumab maintenance treatment, basically immediately following completion of this chemotherapy, or best supportive care alone. And this is in the context where immunotherapy is really only used as a treatment at the time of progression. So we watch our patients, and then when cancer progresses, then we use immunotherapy. Here, this approach is like immediate, what we call switch maintenance. And when this was done, it's a multinational study conducted in the US and throughout Europe. There's a survival advantage with a hazard ratio 0.69 in the overall population that was treated. And then when you focus on the PD-L1 positive patient population, where generally we see an enrichment and benefit in terms of improved outcomes, the hazard ratio now improves to 0.56. I will point out further that we understood a little bit more about the PD-L1 expression biomarker as per this particular study. In the best supportive care arm alone, which basically patients are simply being observed, the survival was actually improved in the best supportive care arm, suggesting that the PD-L1 positive biomarker actually associates with improved prognosis as well in this particular study. All right. So what about second-line treatment? So this was a maintenance approach, and I think that's kind of considered the standard of care essentially worldwide now. So after platinum chemotherapy, maintenance immunotherapy. Now, what about for patients who may not opt for, let's say, a maintenance approach and say, listen, doc, I need a break. I'll follow scans closely, and, when treatment, let's say when my cancer progresses, I'll be ready to receive immunotherapy then. So then what are my choices at that point? So then your choices expand. Here, it's avelumab, still also available. So you could use that as maintenance or treatment at the time of progression. Nivolumab is also available. And then there's also pembrolizumab. All 3 of these are now full regular approvals. Previously, both avelumab and nivolumab had accelerated labels. They've now converted to regular approvals. on the basis of their subsequent randomized phase 3s in a similar disease indication or earlier disease that demonstrated they established their clinical benefit. But the response rates here are basically between 16 to 20%, slightly lower for avelumab. Nivolumab and Pembro are roughly around 21% and consistent across these two trials. And again, this is a very reasonable treatment option for patients who decide to wait until after progression on their subsequent scans. So that's certainly an option. Okay. So what about immunotherapy? So a reasonable treatment choice for patients who have progressed after chemotherapy, or can be done as what we call a switch maintenance approach. Either one is quite reasonable, and patients can do it based on patient preference. Only immunotherapy to date that has shown a survival benefit over an active comparator, actually in any treatment setting, to be honest, in bladder cancer, in advanced bladder cancer, is actually pembrolizumab as part of the KEYNOTE-45 study. There have been no head-to-head trials of immune checkpoint inhibitors against each other, so it's not clear which one is necessarily better. But frankly, whatever you have available to you is probably what you should be using. Now, there are other ongoing studies that are really critical to look out for. Checkpoint inhibitors in combination with chemotherapy. I'll kind of quickly mention that because that area has really settled itself out now. And then also CTLA-4 inhibitors. Checkmate 901 is a really important study to look out for that is looking at a higher dose of a CTLA-4 antibody called ipilimumab that may have improved outcomes, even improve that response rate in first-line setting. There are chemotherapy plus trials looking at, let's say, pembrolizumab plus chemotherapy, atezolizumab plus chemotherapy. KEYNOTE-361, which looked at pembrolizumab in combination with chemotherapy, negative study all around, really no added benefit. The atezolizumab plus chemotherapy study, which was the IMvigor130 trial, it did meet its first of its co-primary endpoints with progression-free survival, and we're still waiting for the survival data to mature. But that magnitude of benefit is really nominal right now. And I think most of us in the field feel that while the study may be positive from a statistical standpoint, we're not quite so sure how clinically meaningful it may be. So as of today, and probably for the foreseeable future, until other data from other trials read out, it's really either chemotherapy or immunotherapy in the first-line setting, really not the combination of the two. So takeaway here, consider immunotherapy maintenance or second-line immunotherapy, depending on the response to platinum-based chemotherapy. But upfront, first choice is either chemotherapy or immunotherapy in the first-line setting. I will quickly touch on immune-related adverse events or checkpoint inhibitors. How do checkpoint inhibitors lead to adverse events? It's through reactivation of the immune system. Now, primary target of PD-1 antibodies are essentially the effector T cell, the CD8 positive T cell, but through co-interaction through other arms of the immune system, it can basically reinvigorate or unmask nascent autoimmunity through this kind of autoimmune inflammatory response across multiple organ systems. Skin is the far and away most common pruritus, skin rash. Easily 2/3 of patients will get it. Less commonly, pneumonitis or GI inflammation, which will manifest as diarrhea, can happen between 3 to 5% of patients with any real clinical significance that requires steroids. Endocrinopathies can happen, all of these things, and they vary, within each disease and also to some degree which type of immune checkpoint inhibitors. So CTLA-4 antibodies we see much worse. And there are a lot of other guidelines that are now published and well codified across these clinical practice guidelines in these professional societies, including ASCO, ESMO, and CCN, and then recently updated SITC, which is a Society for Immunotherapy of Cancer. So I invite all of you to visit these respective websites to get updates on these guidelines. But the primary message here is early identification of an immune-related adverse event, and majority of the time, it's early initiation of steroids to prevent escalation into higher grade toxicity. So Terran, let me hand it back to you about our case.
All right. Here's Sean. He achieves continued regression in his cancer and further reduction in his lymph node with avelumab maintenance. 18 months later, he experiences progression with increasing and new lymph nodes, and he has new liver metastasis. Which treatment option would be most appropriate for Sean now?
Erdafitinib wasn't the right choice because the patient didn't have any actionable alterations. And so therefore, erdafitinib would not be a choice. But although if the patient did have a actionable alteration FGFR2 or FGFR3, then it would be a reasonable choice. So what about therapy in the third line setting and beyond? Trials should always be considered, but again, they should be appropriate for the patient and their individual situation. Not a trial isn't always the right choice, but it can be in the right clinical scenario. And there are no randomized trials comparing enfortumab vedotin and EV versus sacituzumab govitecan, SG, and erdafitinib. And so we're not making comparisons between each one of them, but each one has a different level of evidence to support its use. So in the third line setting and beyond, certainly EV has risen to preferred status, driven primarily by data from the EV301 study that showed a survival benefit in the third line setting against single agent chemotherapy. Erdafitinib is a preferred option for patients with FGFR2 and FGFR3 alterations. It is a first-in-class and only-in-class molecule for us in bladder cancer for patients with these alterations, although there will be other agents that are currently being tested in this class as well. And then alternative chemotherapies that the patient has not received in the past can be a reasonable choice. Heck, even accelerated MVAC with growth factor support. And so in very limited scenarios, might a patient be still a candidate for this type of such an aggressive approach? And then lastly, sacituzumab govitecan is also listed on the basis of a single-arm study that led to accelerated approval in April of this year. So I want to focus now on kind of this new class of drugs called antibody-drug conjugates, of which enfortumab vedotin and then sacituzumab govitecan are both members. What are antibody-drug conjugates? And you can break down the word. Antibody drug is, the payload or the working part of the drug that we want to co-administer along with the antibody. And conjugate basically means it's linked together. The term linker, which can be either cleavable or non-cleavable. And this is where I think that in our kind of biotechnology world, this is where I think that over the last 5+ years, our companies have really done a great job of developing better technology, both to highly customize the FAB portion of the kind of working end of the antibody, which is very antigen specific. It'll only bind certain cell surface receptors. That's the purpose of an antibody drug conjugate. And then the linker technology, which remains highly stable in the peripheral circulation, so that when this antibody drug conjugate, this whole molecule here, binds on the surface of the cancer cell, it then gets internalized, usually included in what's called a lysosome. And then in the case of EV, it's a protease cleavable linker. If it's SG, it's a hydrolyzable linker. And once that linker is cleaved, it releases the payload in the cancer cell or the cell of interest, and it limits systemic exposure, or it can't completely eliminate it, but it does limit the systemic exposure to that particular drug. And so focused activity for where the drug needs to go, limited exposure for safety purposes for where the drug you don't want it to go. In the case of EV, the target is a protein called Nectin-4. Its payload is a highly potent microtubule agent called monomethyl auristatin E. Yes, that's a mouthful. SG, the target is TROP2, which is ubiquitously expressed on a number of different epithelial cancers, urothelial being one of them. And then its payload is SN38, which is the active metabolite of irinotecan. So basically, between these two drugs, there's really nothing that overlaps. So you can use both drugs in the course of the patient's care, which is actually really attractive, especially because, many times you have me-too drugs. In this case, yes, they are both antibody drug conjugates, but they're quite different, and they should be non-cross resistant. So what was added in the label for enfortumab vedotin is that there's level 1 evidence as a third-line agent. So after chemotherapy, after immunotherapy, it showed a survival benefit versus single-agent chemo like taxane in the third-line setting. So it's a preferred agent there. But there was also another study called EV201 Cohort 2, which looked at the role of enfortumab vedotin after immunotherapy in cis-ineligible patients, that looked at enfortumab vedotin, and maybe this is a drug that we can use earlier in the course of treatment and just say, listen, instead of just third line, what about second line? What is his activity and role in second line setting? Again, with those patients who, let's say, receive immunotherapy in the first line, are not good candidates for platinum-based chemotherapy, and let's see, antibody drug conjugates, the safety efficacy profile is supposed to be a little bit more balanced and maybe a bit more favorable for our patients. So that was the phase 2 study. It had actually 2 cohorts. Cohort 1, that was the accelerated kind of label back in December of 2019. I won't discuss it real quick, but again, it was after previous platinum-based chemotherapy and immunotherapy in the third line setting. It was the precursor to the EV301 trial that led to accelerated approval. Cohort 2 was 89 patients who previously received immunotherapy alone and were platinum naive and cisplatin ineligible, 89 patients. And what we observed in this study that we presented at ASCO in 2021, GU ASCO 2021, and then later published it earlier this year, it was a response rate of 52% and 20% of patients achieving a CR. 77 patients had at least one post-baseline scan. That 88% of the accessible patients had at least some decrease in their tumors, telling you this the drug is quite active and perhaps could be a very active option in patients who, let's say, receive first-line treatment, and then, let's say are not good candidates for platinum-based chemotherapy and receive treatment in that setting and could be a very good option. So the FDA considered it. So when the FDA looked at this data in combination with EV301, the added part of the label was that EV could be considered after any first-line treatment. So if you receive chemo first and there's progression and you don't want to reach for immunotherapy because the patient's progressing very quickly and you're not, immunotherapy is not likely to work, and you want to reach for EV, you actually can. So what about EV301? So this was the confirmatory phase 3 that supports level 1 evidence for the role of EV in the third line setting. After chemo, after immunotherapy, 608 patients who were randomized. Primary endpoint was overall survival and a key secondary endpoint of PFS. This is as positive a study as you're going to get, demonstrating that enfortumab vedotin is clearly a better choice in terms of efficacy as compared to single agent chemotherapy. Where is the field headed? So, for those in the bladder cancer world, we're eagerly anticipating and excited about the combination of enfortumab plus immunotherapy. This was a kind of a dose finding and kind of signal finding study of 45 patients in the phase 1B/2 setting. EV103 is kind of a broad platform, phase 1 program to kind of test EV in combination with other agents in a variety of bladder cancer disease settings. And so this study looked at 45 patients who were treated in the first line setting with EV plus Pembro. We really didn't expect to see this, but heck, it's a 73.3% objective response rate, close to 60% CR rate. And what's quite also, enticing to see is over basically 2 years median duration of response, which is quite incredible. We've never seen, a response data that quite looks like this. And so obviously we need randomized data. We need larger data sets to support, seeing something like this. It's only 45 patients in a kind of a hand-selected phase 1 setting. So 2 trials to look out for: cohort K, which is EV plus Pembro versus EV alone, and cis-ineligible patients. Enrollment is fully completed, actually completed, I think it's September-ish. And then the phase 3 trial, which is currently ongoing, which is EV302, which is EV plus Pembro versus platinum doublet, platinum gemcitabine, either cis-gem or carbo-gem. It's a multinational randomized phase 3 trial that is currently ongoing and accruing patients. And what about SG? Several studies are ongoing, but the completed study that's been reported out was cohort 1 of the Trophy U01 study. I won't kind of labor the point of how, the phase 1 development program, but I'll focus on kind of the registrational trials that led to approval in April of this year. Again, this is the TROP2 antibody-drug conjugate in cohort 1 of this study, which was 113 patients who had progressed on both platinum chemotherapy and immunotherapy, basically the identical disease setting in which EV was tested. The response rate was 27%, CRs in 5%. Here's a waterfall plot, gives you a sense of the breadth of activity. Most people, if they're doing kind of side-by-side comparisons, there certainly is activity, probably not as robust as what we see in EV, but it's certainly active and probably more active than what we would expect with single-agent chemotherapy. The Tropic study is the randomized phase 3 that is comparing SG versus single-agent chemo in the third-line setting, just like EV301 that's currently ongoing. Try not to put too much weight on trials like this, primarily because it's a single-arm study, so the progression-free survival and overall survival they are what they are because it's a single-arm study. We need randomized trials to really interpret anything as it relates to PFS and OS. Okay. What about adverse events? Very, very different than EV. So the things that really, really stand out here in terms of the safety is the myelosuppression and GI toxicity. That's the main thing to watch out for. So neutropenia, rates of febrile neutropenia, need for growth factor support, that's a standout. Makes sense. SN38, irinotecan, that part makes sense. And then the other is GI toxicity, also makes sense. So the rates of diarrhea, those are the 2 main things to watch out for. But they're really not overlapping with EV. EV is hyperglycemia, some skin toxicity, even cases of Stevens-Johnson syndrome and neuropathy. So they really don't overlap with each other too much as well. This is the Tropic study. This is the study that I alluded to, which is currently ongoing. This should support the accelerated approval and hopefully demonstrate definitively a survival benefit and convert the accelerated to a regular approval for SG. Basically, identical trial designed at the EV301. Patients with platinum progressed and immunotherapy progressed urothelial cancer are randomized to either SG versus treatment physician's choice of single agent docetaxel, paclitaxel, or vinflunine. And the primary endpoint is overall survival. And currently this study is ongoing, right? So what about other agents? Now let's talk about molecularly targeted agents, specifically erdafitinib. This is the one drug that we have currently available, but there are other drugs that are currently in development. What is erdafitinib? It's an orally administered pan-FGFR tyrosine kinase inhibitor. There are essentially 4 isoforms of FGFR, so 1, 2, 3, and 4. The main driver alteration that we see in bladder cancer, probably 95% of the time or more, is in FGFR3, either hotspot mutations or translocations. If we see them, it's really going to be FGFR3. And of the times that we see them, it's roughly about 20% of patients with advanced urothelial cancer. There may be some association with some, tumor microenvironment phenotypes that associate with FGFR mutations. But when we really look at the data in patients, let's say Checkmate 275, we look at FGFR3 mutant patients versus wild type, the response rates with immunotherapy are actually quite, similar, if not identical. But there is some data to suggest that the immune microenvironment is a little bit different in patients with FGFR3 mutations, but it's not been proven that they don't necessarily respond to immune checkpoint inhibitors. There are currently phase 3 studies that are currently ongoing, but erdafitinib is certainly a reasonable choice. The basis for its approval was the BLC 2001 study.
Thank you for listening to the Practicing Clinicians Exchange podcast. To claim your credit, please visit pce.is/GIGU. And while you're there, don't forget to check out our website for more complimentary oncology CE/CME activities.